welcome everyone. My name's Dave Belshaw. I'm a Health Programme Manager at the Academic Health Science Network, and I'm going to try and share this webinar today. We will circulate the presentations after the event, so you don't feel as if you need to scribble frantically notes like we all used to do when we got together face to face for events. And the event is going to be recorded and shared, just to let you all know that. We'll post the link after the event for those people who couldn't make it today. You can join the conversation on Twitter. We have a hashtag, WCCHNENC Well Connected Care Homes. The next slide, please, Sarah. So we've our speakers today. We've got three main speakers. There's me. We've got Tony Roberts, who's our Patient Safety Collaborative Programme Lead at the Academic Health Science Network. And we've also got Karen Hampshire, who's a clinical educator, joining us from Hartlepool in Stockton. I'm sure you've all seen the programme, but just to reinforce that we've got quite a packed agenda. We've said to take 2 hours. It may not take that long, but we've put that time aside. So we will see how we get, but we didn't want to rush through things. So we're going to think about some context for today's webinar. We're going to look at soft signs, News 2 and SBARD, and then we're going to have a little look at Oximetry and why that's becoming important in our COVID response. Next slide, please, Sarah. So just to do a little bit of introduction and context, and the first bullet point is really important for us here. It's because actually we've had a well-connected care home project for coming up to 3 years now. And actually there's probably a number of people on the call who've been engaged with that process or have worked alongside us over those last 2 or 3 years in order to develop a digital response and a digital approach to working in care homes. And that journey started back in the vanguard of Newcastle, Gateshead and Sunderland about 3 years ago, and since then has grown. And currently we've got digital projects and deterioration projects in care homes in Sunderland, Newcastle, Gateshead, Stockton, Durham and Darlington. More recently, we've got projects in North Tyneside, South Tyneside, Northumberland. So North Cumbria and South Tees are starting out on their digital and deterioration journeys. So there is work happening across the whole region, and it's been going on for quite some time. And because of that, we've got some really fantastic examples of how News 2 and soft signs are being used in care homes across our patch, and we want to take the opportunity to share some of that good practice. Where it has been really successful, it's really important to think that actually has been in partnership with the system that's surrounding the care homes. It's not just a care home intervention, it's not just a community nursing team intervention, it's a joint intervention. And where it works really, really well is when those two things are joined up and we've got people working on the same pathway using the same common language. And that's one of the objectives that we want to try and create. It's also important that we think about News 2 because of the next 3 bullet points. All of our acute trusts are using News 2. So News 2 is the National Early Warning Score, and the number 2 because it's the second variation of that score. And it's a nationally mandated tool for identifying and categorizing deterioration. And 100% of our acute trusts are using it. The ambulance service is using it. And about 40 to 50% of primary care teams and GPs are starting to use News 2 in a variety of appointments. So actually, as a standardized score, it's a really useful thing for us to start thinking about when we think about deterioration, either for ourselves as individuals or for the people that we're looking after. And if we can create a common language around that, then actually that's a really, really helpful thing to do. Next slide, please, Sarah. So what we've been doing is we've been more recently doing some scoping work on digital capacity across care homes in response to COVID. Today's session is not about COVID, it's about deterioration generally, but we do have to recognise that we are in an incredibly difficult situation in terms of COVID for our care homes. And I'll come on to that in the next slide a little bit more. We've actually started some pilot sites looking at using News 2 measurements and specifically oximetry on care home staff at the beginning of shifts in order to try and help identify if staff are becoming unwell. That's been a really interesting experience for us. We've only done it in a couple of care homes to try it out, and we can give some feedback about that separately if people are interested. We've got a really good commitment from the health and social care community to work together on this as we move forward, as you would expect. And the other thing to say is that this is part of a national conversation, and the academic health science networks across the country have worked together over the last 4 or 5 months pre-COVID to agree that if we did work on deterioration in the care home sector, that we would all agree to stick to 3 broad principles. And those broad principles are the things that we're going to talk about today. The first principle is that if we are going to think about deterioration in a care setting, then we need to think about the soft signs of that deterioration. So what is it that we're seeing that's making us worried about Dave or Fred or Vera? And can we create a language around that to help us better describe and understand what it is that we're seeing that's making us concerned? The second principle is that when we're thinking about deterioration work in care homes, we would all encourage the use of News 2 for the reasons that I described earlier. It's a commonly used tool across the whole of the deterioration pathway in acute care and ambulance services, and increasingly so in primary care. So if we can use a common tool to measure that and therefore measure the deterioration, that actually is a really helpful thing to do. The third principle was around structured communication, and we're going to look at that again today. A commonly used tool across the whole of the NHS is SBARD. So we've incorporated that into our regional tool, our local tool, again, so that we can start to create a common language across that pathway. And the final point is that what we're going to use today, we're going to introduce you to a suite of training resources that have been developed nationally by the AHSN and Health Education England that actually can be really, really helpful. There's a whole range of short 2 to 3 minute videos on specific topics that when we're thinking about deterioration and we're thinking about News 2 scores are actually really, really helpful educational tools. And we're going to use some of those in the webinar today, and we're going to introduce you to them towards the end. And then they're there for you to use as much as you like. Next slide, please, Sarah. We do have some challenges across the North East and North Cumbria. We've got 7 CCG groups now. Some have recently merged. We've got over 800 care homes, and that's just care of the elderly care homes. If we think about CCG registered, CQC registered homes, actually we've got hundreds more. But for the purpose of this, we're thinking about older age people and care homes. There have been some difficult conversations recently around funding models, around capital investment, and how do we actually fund kit for care homes in terms of actually how do we fund pulse oximeters and how do we fund blood pressure cuffs and how do we fund digital tablets. And actually that's a really complex area that regionally we're trying to work through with NHS England colleagues. But I'm aware that actually despite those difficulties, there's quite a lot of investment happening currently in care homes in terms of digital in response to COVID. We've got some issues in that the digital systems that have been adopted do vary, and we just need to consider that as we move forward. There are clearly issues around News 2s being used but not always communicated, and I think that's one big problem. The big advantage of News is that if you take a News score on Dave in the care home because you're worried about him and his News score's 2, and you dial 999 and an ambulance crew turns up 40 minutes later and they take Dave's News score and it's 3, then that's an indication that Dave's deteriorating. He's becoming worse. His News 2 score is going up. If the ambulance crew then conveys and takes Dave to hospital and he ends up in the ED department and they repeat the News score in the ED department and Dave's News score is 4, then actually within the space of an hour, my News score has gone from 2 to 4. And that's a really significant piece of clinical information that can really help decide how to best help. So News 2 is really important, but it's important that we don't just do it a single time in isolation, that it's done repeatedly along that care pathway, because it's the difference in News scores that gives us an indication of something going wrong. We've got some challenges in terms of how we do training now, because we're trying to do things like this remotely. This is actually our first ever webinar on Teams of this size. So bear with us, it might not all go smoothly, but we're hoping we'll do our best. So it presents some challenges in terms of how do we train community teams and care home settings to use digital equipment and do News 2. And the last bullet point, which we don't want to dwell on too much, because this is not a specific COVID-19 piece of work. This predates COVID-19, but we can't get away from the fact that COVID-19 has hit our care home sector incredibly hard and has presented some challenges that actually have been incredibly difficult to manage and work through. So we need to take this work in the context of COVID, but recognise that it is a piece of work that started long before we faced these challenges. Next slide, please, Sarah. So we do have an agreed approach to doing this kind of work as we move forward. We are hosting this webinar, but there is also an offer to host some more local webinars if that's useful in the future. And it'd be great to hear from you as to whether or not you think that would be good. So whether we did some specific webinars for Hartlepool and some specific webinars for Sunderland, we're quite open to doing that, but only if you feel that it actually would help. We are going to look at the nationally agreed training materials because actually they're really good and there's been a lot of effort put into developing them. But we do want to think about how we develop and locally deliver that with local experts and the skills and knowledge that we've gained from working alongside our care homes in the North East over the last 2 or 3 years. Next slide, please, Sarah. So what we're going to focus on today and use as the structure for the next hour or so is a tool that we developed and we called Is My Resident Unwell? And actually we spent 6 months developing the tool and we started in the summer of last year in 2019. And one of the first things that we did was we recognized that actually there were a number of tools already available nationally. So we had tools such as Stop and Watch, Significant 7, Freed, and actually there are a number of tools which look at soft signs of deterioration. And we put a panel together of community nurses and educationalists and some care home representatives and said, let's review these tools and is there anything that we can just adopt? And what that panel said was that actually we like bits of all of them, but we don't like any of them enough to just go ahead and do it. We want to write our own. So we then had that panel of experts actually sat down and wrote a tool over 6 months last year, and that's what we're going to present to you today. Actually, we originally launched the Is My Resident Unwell tool in the Durham Centre at the end of February, about 3 weeks before lockdown hit. And I guess from looking down the list, a number of you were actually at that launch. And at the launch, we had a lot of care home staff and a lot of community nurses, and we got some very, very good feedback. And then unfortunately, COVID hit the country, and actually that forced us to rethink our plans for rolling out and supporting the use of Is My Resident Unwell in care homes. And we've listened and we've thought, and we've not pushed ahead with that. But over the course of the last 2 or 3 weeks, we've had care homes saying to us, do you know what? We are more ready for that than we have been. And actually, we do have some space and some capacity now. That's not across the board, but there were a number of care homes saying to us, we want to start thinking and looking ahead. So this is in response to that, we've decided to relaunch the Is My Resident Unwell tool. And that's what this webinar is about today. We'll come on to next steps at the end of the webinar, but we hope to continue to push and support the use of the tool through a variety of different methods over the next 6 months or so. So next slide, please, Sarah. So this is actually the first page of the Is My Resident Unwell tool. And the important thing to think about here is what the tool is for. So this tool is meant to be used at a point where you've already noticed that there's something not quite right with Dave. And then actually you're worried, but you're not quite sure what's going on. You might not know exactly what the issue is, but you are concerned enough to think, do I need to have a conversation and refer Dave on? So the purpose of the tool is at that point, you would go and get the tool, whether that's a digital version or a paper version, and you would use that tool to pull together a set of information that's really helpful and really relevant for Dave before you go and make that referral. Whether it's picking up the phone and having a conversation with a community nurse, or whether it's a primary care referral, or whether you're using a tablet to do a digital referral into your local system. So we have a tool which starts to think about what is it that you're seeing, pull together some useful information, and to write that down into a single place before you make contact with the next next bit of the system. And that just really helps you to coordinate your thinking, get the right information down in one place, and then pass it on. So that's what the form's for. It isn't a replacement. If you think the situation is life-threatening, you always ring 999. But that's just a little bit of context. So now we're getting on to the important bit, which is actually what is in the tool. And I'm going to pass you on to Karen Hampshire, who will introduce herself, I've no doubt. And she's going to talk you through the first couple of bits of that tool, play some of the instructional videos, and then hopefully we'll start to get into some of the detail. So thank you very much for coming along today. I hope you find the session useful and informative. Keep your questions coming in on the chat. We do have two people, and their sole role today is to monitor that chat box and make a record of questions and comments that are coming in. So please do engage with us, and we'll muddle through our first ever Teams webinar, and hopefully it'll be useful. Karen, can I pass over to you?
You certainly can. So hello everybody. This is very bizarre not being able to see anybody particularly, but thank you very much for inviting me to speak on today's webinar. My name is Karen Hampshire. As you can see there, I'm a clinical educator here at North Tees and Hartlepool Foundation Trust, and in regards to the work that the AHSN that I've been involved with this tool is my Resident Unwell tool. As Dave said, it's gone back for quite a while, but prior to this I have been involved in the North Tees and Hartlepool Education Alliance, which meant working with all of the care homes here at Stockton Hartlepool and working with them with many of the educational issues or topics that we wanted to cover. And also implementing the digital news kit into our area. However, that it blended really well with what the work that the AHSN were doing, and principally by getting our care home staff to do news and to record news with their residents. Now I'm going back 3 years for this. So this does way precede anything that COVID and the challenges that's brought on. So if we think about the tool, if we move to the next slide, Sarah. And now the tool itself, as Dave said, that was the first page that he showed. And then when you look at the next one, we have them in steps, step 1, step 2 and step 3. So if we think about the first step on the tool, and it simply says there to recognise and record the changes. How I see this and how the care staff who would use this see it on the feedback that I've had from them, this is what we would call the soft signs, that many of you have probably heard of, but certainly anybody who works with the residents who work in care, or all of us probably, we all know what we mean by when we get the gut feeling that something is just not quite right. We see somebody who we know them fairly well. We wouldn't be able to do this on a stranger, but somebody who we know fairly well, so certainly the carers in the homes, they would have their resident, let's say it's Dave again, and they see him, and for some reason it's just they get this gut feeling that something is just not quite right. That's so powerful and so important, and I think it's the work I've been doing with our carers is that we're getting them to go with that feeling and have that feeling that they've got to be really valued. Sometimes the feedback I get is that maybe the staff find it difficult to either articulate what it is that's wrong with the resident, or they haven't got the confidence, because quite often it is just a case of they're just not very well today, and they feel a bit foolish by that's the referral. They're a bit chesty, or they're just not very well. So they feel that the staff felt like they wanted more. And I think if you look at this here, it's like a checklist, and this enables, I suppose, the staff to check through, is there anything else? As you can see on here, how are they presenting today? So are you worried about, are they becoming restless, agitated? Are they flushed, sweaty, cold, clammy? Are they less mobile than usual? Is there any new or complaints about any kind of pain, skin colour, condition, shortness of breath, and so on? I hope you can see the slides clearly there. Confused, do they feel sick? Have they got cold hands and feet? Are they off their food? Are they off their drinks? Changes in their urine, in the colour, in the smell, in the frequency, or in their bowel habits. So they're all there as what we would class as soft signs. It may be that actually it's a no to all of them, and they're just not quite right. It might be something really personal and really specific about that resident, and that it's just simply behavioural, and where they would normally be able to hold a conversation or do something, today they just aren't. Ask the resident. There's a space at the bottom of there as well that allows you to write down the words of the resident, which is really important also. So this is step one. So at the minute, what we presently do is we have a referral, and the carer would see some of these soft signs, and they would maybe refer to whatever the referral system might be, whether it be 111, SBARD, or of course, if you're really concerned, it would be 999. And again, at the minute, the feedback from the people who receive the referrals, so our clinicians or GPs or whoever it might be, they sort of say that the referrals are vague, that it is, they're just not well, chesty, and that's all that's written on a referral form sometimes. And sometimes there isn't a lot more information that can be given, I don't suppose. However, it's not very sort of good from their point of view when they're trying to either triage the referral or try and glean how important or what's going on. So with this tool, it's then allowing the carer to give more information. It's there. If we standardise it, it works really, really well. If the carer is still unsure, it's always about still passing this information on. Now, it might be that it's not the same carer who fills in step one as then moves on to do step two, which we'll talk about in a second. It could be that it's different people. That doesn't matter. It's just that first person, and quite often it's the junior members of staff that might see these soft signs. So then again, it gives them a platform to write down their concerns, and it's excellent as an evaluation or audit tool as well. We did pilot this in our homes, and I've got a couple of bits of feedback from the homes. It wasn't for very long because we were sort of cut short with our pilot, but certainly some of the positive feedback we got was that they were trying to create a better or improved referral tool themselves, so I felt this was excellent. They liked the pictures, so they liked the way it was laid out, the picture format, and it was a tick box, so it was simple and it gave them prompts. I've already said about it doesn't need to be the same person filling it in, so quite often it was the junior carer who did this, and then the senior carer who then did the news, and so they worked together. And it was a good aid memoir for when somebody did, so when the referrer phoned them back and wanted information, one of the negatives was that when the referrer, say the clinician, phoned back about the referral, that person who did it wasn't available. So it was a case of, well, I don't really know, I didn't do it. Where now that the homes were keeping these handy or electronically, it doesn't really matter. They could have a look, and they could have a look themselves and pass that information on. So that was really good. Some of the negatives that we got feedback from was they felt it was a bit repetitive, because they were doing a referral form and they were doing this, but because of the nature of it being a pilot, we sort of needed to do that. And it might well be that that's still the same thing, that you've got a referral form and then you have this as well, but it may be that these get blended together and that we use the same form for both. Other criticism was that or negative bit was that the wider services weren't aware of the tool. Well, hopefully that will improve because we'll be able to roll this out. And the other thing was they felt that because when they did the referral, it was either via email, so it meant scanning this on, so it was just another char was the word that they used. But still, again, I think if you start to see the benefits of the improved communication using this, the scanning on of the document, it might not be such a char, maybe. But there's a video that goes along with soft signs that's quite excellent to watch. So if we maybe watch that next, I think it's there. Yeah.
Hello. As a carer, you notice that someone doesn't seem to be quite themselves, and you may be worried that they become ill. Sometimes it can be obvious that someone is unwell. If, for example, they are in severe pain or become very confused. Other times, the signs might be much harder to spot and less specific. Soft signs are the early indicators that someone might be becoming unwell. You do not have to be a healthcare professional to recognise these signs. Often, family and friends will pick up on the subtle changes in a person's behaviour, manner, or appearance. Family concerns should always be taken seriously, even if you think the person is fine. Soft signs can be related to someone's physical presentation, mental state, or behaviour. Examples of changes in a person's physical presentation could include being short of breath, not passing much urine, and being unsteady when walking. Examples of changes in someone's mental state may include feeling more anxious or agitated, or being more withdrawn than normal. Changes in behaviour may include altered sleep patterns, increased tiredness, or being very restless. It is good practice to ask the people you care for, "How are you doing today?" Allow them time to answer the question in their own way. You should encourage friends and family to tell you if they notice any soft signs. Some soft signs may be very individual to that person, and it is worth making a note of any of these in their records for future reference. Soft signs are particularly useful for people who have difficulty communicating or understanding information due to dementia or learning difficulties. Imagine you are caring for Mr. Harris, a 76-year-old male who has done the newspaper crossword every day for the last 55 years. Mr. Harris unfortunately gets urinary tract infections frequently. You've noticed that whenever he is developing a urinary tract infection, his ability to concentrate starts to reduce. Therefore, his soft sign is not being able to do the crossword. By learning about soft signs, you may be able to spot deterioration early and act to protect someone from serious illness. Your organisation will have an escalation plan if you spot a soft sign. This may involve using the National Early Warning Score system or escalating your concerns to a healthcare professional or senior colleague.
Come back in action. Okay, good. So that I think sort of covers the soft signs, but I don't think we can ever underestimate the value of the care staff and how they know the residents so well. So it's going with that gut instinct that they have. So once they have these concerns, of course, they're going to then escalate it or tell somebody that they've got this, that Dave isn't very well, and they're going to have a look at that checklist, try to be able to sort of say why in a bit more detail, and then it might be themselves or somebody else is going to move on to step 2. So this would be your recording of your news score or your hard signs. So this is going to be the 6 readings, which will be your temperature, your pulse, your respirations, blood pressure, oxygen saturation, and if they're on oxygen or not, and their conscious level. So it's all there, and so it's good as well. It's clear. All of those recordings can be seen really, really clearly, and I think it's about a process. So it's about a process that's always gone on. It's from seeing those soft signs, we're then moving over, we're doing recording the hard signs to then be able to pass on to the clinicians, so that they can get a better picture of what's going on with them. So what the care homes would need to do is have the staff trained to be able to do and record the news. When we've been doing it here in Hartlepool and Stockton, all of our care home staff are now trained and are all using news as their assessment tool. The news score, you would need to have a baseline, so whether that's when the resident first comes in or on a regular basis would be ideal. So the minimum that will be done is every month. Then it would be, when you get that gut feeling, you would then go and do the news score. You would have something to compare it with. Is that gut feeling right? Or, how worried should I be? But always remembering that news is a tool. It's just an assessment tool that's a small part of everything else. So what the resident looks like, how they're presenting, and then the news score comes just to fill up and give you a bigger picture. So that referral would still go on. I think it's really important to still do all 6 of those readings. It might be that the clinician is only focusing on 1 or 2, but the new score as a tool, it's there to warn people early. It's a national early warning score, so all of the readings need to be put there, and then the new score can be worked from that. And as Dave said at the beginning, this is seemingly the assessment tool that's used across all areas. So again, it's bringing everybody up to speak the same language, I suppose. I'm going to just give you an example actually of a really simple, it doesn't always have to be when someone's extremely unwell or obviously unwell. An example I've got is that we had a gentleman in one of our care homes, and he was chesty. He wasn't himself. So they did the referral, and the community matrons came and they said, yes, I think it's a chest infection. So they give him antibiotics, and they also said, will you do the new scar each day? Just to check. It's good practice, and as part of their plan of care is that every time they prescribed antibiotics, they would then ask for a new scar to be done daily. So the care home staff did the new scar day 1, it remained the same. Day 2 of the antibiotics, he didn't seem to be any different particularly. He didn't seem to be any better either, but the new scar had increased. So they informed the community matron, who then came back and changed the antibiotics, and he then began to improve. Now, what both the care staff and the community matron said is, rule of thumb, they would wait 72 hours of antibiotics, so they would wait 3 days to then see if they were helping or not. But what the new scar, by recording it each day, allowed them to do was, well, what it said it would do, it warned them early that he was deteriorating. So they really felt like they stepped in earlier than they would have done necessary and acted on so he didn't deteriorate, and the outcome, well, it would be that he stayed there and he got better. So I think that's a really good example, and it's quite a simple example of how we can prevent deterioration with the residents in the care homes using this, and just being sort of getting the observations and communicating pretty much across the teams. I've also, next slide, I think, Sarah, is I'm going to just quickly show you, these are some statistics that I've managed to gather together from our usage of news. And this is related to the COVID-19 outbreak and when the homes locked down, because when that happened, it was even more vital to keep a closer eye on the residents, but also to be able to allow our clinicians to be able to sort of keep a close eye, and again to check to see if it could warn us early that there was something going wrong so we could act on it. So although we were doing really well, our homes were already using news. We did then up the ante and really encourage them to use it once they went into lockdown, to do it more often than ever. Weekly ideally, but I do understand that it's not always possible. So if this is just the key, it would have been good to see them on the same side, but it doesn't matter. If we see on here, I'll remind you what the colours are, but this is our Stockton homes, and if you see sort of as the months have gone by, that's the blue is the usage of news, so the recordings. Now the yellow line is the occupancy. The green line would be the maximum occupancy of the homes, but that's where we want to be heading really, because every resident ideally would be having a news score done. And if we look at the red line, is when the lockdown occurred, and it was fantastic response. You can see there that the blue line, the trajectory went up quite rapidly, so that was really good. It has tailed off a little bit there just over this last month. Again, something that we can keep a real close eye on, because we shouldn't be relaxing. We are still in the midst of it, and doing the new scar is as, if not more important. So really good. So I'm very proud of the homes and what they've done. If you look at Hartlepool, it's a similar picture, and it continues to massively over excel. So again, really proud. You can see there that the homes are using news and recording news fantastically. So that's really positive. So there, I think that's me, and I'm sure if there's any questions on sort of any of these that I'm talking about, you can ask me at the end. But so that's me. We'll look at a video that's going to explain more about news too.
Hello. News stands for National Early Warning Score. The system is widely used across healthcare settings in the United Kingdom. It uses a set of observations or vital signs to quickly recognise if someone is becoming unwell. This is because a change in vital signs suggests worsening health. For example, a rise in heart rate or temperature may suggest an infection. The 6 vital signs used in news are breathing rate, also known as respiratory rate, the level of oxygen in their blood, also known as oxygen saturation, heart rate, also known as pulse rate, blood pressure, level of alertness, and temperature. All of these vital signs can be easily measured in care homes. Each vital sign scores between 0 and 3. 2 further points are given if someone is on oxygen therapy. Once you add these scores together, you get a news of between 0 and 20. The higher the score, the more unwell the person is likely to be. A score of 5 could mean the person is very ill. The person needs regular monitoring of vital signs whilst an urgent review by a doctor or nurse is arranged. If the score is above 7, the review needs to be very urgent. Many care homes will take a set of vital signs when a resident first arrives to help them understand what is normal for that individual. The new system helps care homes and carers to interpret the vital signs through a scoring system. Your organisation will advise how often you need to check an individual's vital signs. News has been shown to help staff to recognise sick people more quickly and get help earlier. If someone becomes unwell, a carer can give the GP, 999, or the ambulance crew the news. This helps healthcare professionals to quickly understand how unwell someone is and how soon they need to be seen. News has been shown to decrease the number of 999 calls and hospital admissions from care homes. Care home staff also report that they feel more confident and supported to raise concerns when using news. This means that the safety of residents is improved and they have a greater chance of staying in their own home for treatment. It is important that you have been trained to use the equipment for taking vital signs. You will need to use a thermometer, blood pressure cuffs, finger or ear probes known as pulse oximeters for measuring oxygen levels, colour-printed news charts or electronic devices with news software, and a timer or device that can time 1 minute. All equipment must be regularly calibrated and checked. If you find any problems with any of the equipment, you must report this immediately. If you have any questions about news, please speak to your manager or senior colleague.
Thank you, Karen. That was great. I think there's a couple of important things just to pick out from that last little section. And I think the first one is that actually what we're never asking care home staff to do is to make a decision based on a news score. Actually, all we're doing is asking care home staff that at the point that they're concerned is to collect some additional information around soft signs, to collect some additional information like a blood pressure and a pulse and a oxygen saturation level, and to put them together in one place in the form and then pass that information on. So we should never be expecting care home staff to say, oh, well, Dave's news score is only 2 today, so that's fine. That's not what this form is about, and that's not what we're asking. What we're asking is that you collect that information and then pass it on, and the relevant clinician will make that decision. It's enough that you're concerned that you want to refer on. It's enough that you're concerned that you want a second opinion. And that's what the Is My Resident Unwell tool is about. It's about helping you collect all of that information together in a structured way to help you have that conversation and to help the right decision to be made. So that's a really important piece of information that we need to get across today. The second one is that most of the care homes across the patch either have already got a digital solution in place, so they've got a tablet either from Health Call or from Whizzan, and actually all the care home member of staff has to do is input the different physiological measurements. So you have to count someone's respiration rate, count how many times they're breathing, and you put that information into the tablet. And then the tablet actually calculates the news score for you. We're not expecting you to sit down with a complicated chart and then work out what score equals to what, and therefore what the news score is. Actually, that's something that can be done digitally, and we're working behind the scenes to make sure that that does happen digitally. However, I also know that when it works really well, it's because care home staff have worked alongside their community nursing teams, and they've worked through together how to do a news score and how to do a blood pressure and how to count respirations and how to put a pulse oximeter on someone's finger. And actually, when it works really, really well, it's worked in that partnership. And you've got those community nurses and those care home staff working together in order to produce this good quality information. Once you've got all of that, next slide, please, Sarah. The opportunity then comes to pass this information on. Now, you can scroll in and out of this, but it might be a little bit blurry, but that's not important because actually this is page 4 of the document. So if you can imagine back in the days that we all used paper referral forms, this would have been a folded piece of paper. The first page, the front page, would have had on the screen that I showed you earlier. And then if you'd opened it up, the second page would have been the soft signs tick boxes. Now, are you seeing, is Dave less mobile than usual, or has Dave's skin colour changed, or is he eating less? And then the third page would have been the SBARD, and then some contextual information that we didn't ask Karen to cover, but actually thinking about it, it's really important, is that the contextual information is about, does Dave have an end-of-life plan? Does Dave have an emergency healthcare plan? Because all of that's really useful to know when you're on the phone to someone who doesn't know Dave. So, or an ambulance crew turns up and says, oh, actually, we think we need to take Dave to hospital. Well, actually, Dave's got an emergency healthcare plan that might say otherwise. So it's important to understand what the context is for that person. So that those tick boxes are on that form. And there's also a couple of additional boxes around, actually, how worried are you? Because that's a really good indicator. Because if you're incredibly worried, then that should be enough for you to get the response that you need. So if you then turn the page over again, this would be the back page of that folding referral form. And actually, it's an SBAR. So all it is a place for you to collect your thoughts together and write down the information that you've been collecting in the last 5 minutes or so in terms of soft signs and news too. And then to think about, what is the situation? Who am I calling about? What the resident news score? Why am I calling? And then is there any background to that? Well, yes, actually, Dave was discharged from hospital 2 weeks ago after an operation, or Dave's had a medication change recently, or there might not be any background to that. And then your assessment. And actually, at this point, what it's clear to us is that it's absolutely okay to say, I don't know what's happening. We're not expecting a care home member of staff to ring up and make any kind of diagnosis. They might have an indication of what's going on because that might have happened to Dave several times before. But actually, it's okay to say, I'm not sure what's happening, but I am concerned, I am worried. And then as part of that, there's the recommendation. Actually, what would you like to happen? Would you like the nurse to visit? Would you like a call back from a GP? What is it that you think should be happening next? And then once you've had that conversation, you record what the decision was. Well, we made that referral, we had that conversation, and Nurse Hampshire said that she's coming out this afternoon to see Dave. And actually, that needs to be recorded and that needs to be put down there. Now, once you've got this SBAR, we know that some of these SBARs are being done digitally. So if you're on the health call system, for example, this is a form that's on the digital application. And at the end of that, you press go and it magically appears into a single point of access. Some of you will fill out this form and then it might be simply use it as a prompt during a telephone conversation to refer on. But the form is there as a structured communication tool, a way to structure and record the information that you want to pass on so that it's helpful. And I'll go back to Karen's point earlier, is that the person making that phone call or passing on that information might not be the same person that wrote it down. So if you wrote that down before you go off on a shift, or you're actually busy with another resident when the nurse calls back or the GP calls back, it's a really good point of referral to have that information written down. What is it that you're concerned about? What is the background? What's Dave's background? What's the context? What do you think is going on? And what would you like to see happening? And then you record the outcome of that conversation. So we've now got another Health Education England video which talks about SBARD in a little bit more detail, and we're going to play that, and then we're going to come on to a little bit about Oximetry.
Hello. Effective communication is important in everything that we do, whether that is talking to a person about their needs or talking to family members about the care their loved one is receiving. It is also very important that we're able to communicate effectively when we are worried about someone and want to raise our concerns. You may feel that someone you care for isn't their normal self and may be becoming unwell. It can be difficult to communicate when we're under pressure or tired. It can be challenging communicating with so many different groups of people, including GPs, the ambulance service, and community teams. To assist you in getting your message across every time, there are tools available. These are easy to use and help information to be transferred accurately and safely between people. The best known tool in the NHS is the SBARD, Structured Communication Tool. SBARD stands for Situation, Background, Assessment, Recommendation, and Decision. Evidence shows that using SBARD helps with communication confidence and patient safety. Start by explaining the current situation. Introduce yourself and state your role. Explain where you are calling from and what your direct phone number is in case you get cut off. Provide key information about the individual, including their full name, date of birth, and NHS number. Explain what it is that you're concerned about, and if available, use the National Early Warning Score to tell them what the resident's current news is and what would be normal for them. Briefly state the person's relevant medical history. This should include medical conditions, any treatments or medicines that they're on, and whether they have a treatment escalation plan or resuscitation decision. This is where you suggest what you think might be going on and what you think is happening. If you aren't sure what is going on, don't let this put you off raising your concerns. Now think about what you want to happen next. Do you want the person to be seen? If yes, how quickly do you think they need to be seen? You can ask what you should do before help arrives. Finally, summarise your agreed management plan so that you're both clear on what each of you will do to care for the unwell individual. Importantly, remember to document this conversation in the care plan. Practice using SBARD every time you're handing over information to a colleague or healthcare professional, and soon it will become more familiar to you. It may even be helpful to have the SBARD template available next to the phone or in the care plan so that you can use it as a prompt when you need to. Remember, using a tool like SBARD will help you to get your message across clearly and safely.
Thank you. Just before I pass you over to Tony, it's just a quick reminder that we do have a question and answer session available at the end. So if you do have any questions, please do put them in the chat box. And we have a couple of people who are going to monitor that chat box for the next 20 minutes or so before we get to that point. And then we can try and answer any questions that people have got. Tony.
Thanks, Dave. Hopefully everybody can hear me okay. And thank you all for joining today. I'm going to cover a topic which is slightly different from what we've covered so far, but we felt was important to touch upon today. So it's called NHS Home, and also known as the virtual ward, and it concentrates on pulse oximetry. So this is a national programme, and we are expecting a national announcement fairly soon. It's not clear exactly when, but it will probably come out. And some of you, when you hear it, might think, well, how does that relate to the care home work that we've been talking about? And the answer is it's probably not directly going to be used in care homes in most places, at least not initially, although it probably will be joined up at some point. The idea is that there are patients who are at risk of deterioration, but who don't need to be in hospital. So that's both at the assessment stage. So perhaps a GP is seeing a patient and decides that while they're unwell, they're not sick enough to need to be admitted, and that they want to instead monitor them in the community for a while. Or there may be patients who've been discharged recently from hospital, possibly post-COVID, who are at risk of re-deterioration, but again, don't need to stay in hospital, and so can be monitored in the community. It's a bit like the example Karen gave of a patient being monitored because of being given antibiotics. We need to just keep a closer eye on these groups of patients. And particularly in COVID, we think that oxygen saturations and pulse and temperature are particularly important. So those three parameters, so their pulse, their heart rate, their oxygen saturations and their temperature are recorded. And this can be done by patients themselves. So this is why it's not necessarily going to happen, at least initially, in care homes. But a patient might be seen by a GP and asked to monitor their own vital signs, perhaps with help from family or other carers, and to keep a diary, probably 3 times a day, recording those 3 signs and how they feel, whether their breathing feels okay and whether they're generally okay. And then if they start to see a change, or if they start to feel unwell, they can have another consultation, probably remotely, and convey what their signs are, what the physiological signs are, to the person talking to them, the clinician talking to them. And hopefully that makes it easier to detect deterioration, particularly where it's not particularly obvious. So we know in some COVID patients that they can, their oxygen saturations can get poorer, despite them not feeling that much worse and without their respiratory rate going up very obviously. It might go up as well, but you can get this drop in oxygen saturations without it being really obvious. And so this whole approach has been developed in order to try and help detect those people quickly. There are going to be 15 pilots across the country. They might not end up being called pilots. They might be called vanguards or some other kind of name used for them. But the idea is that those 15 will particularly concentrate on what the learning is and how best to do this. There are 310,000 pulse oximeters that have been bought centrally by NHS England, and which will be distributed for these pilots and perhaps other places as well. And we're all going to want to keep an eye on what happens in these pilots to try and learn as best we can. Some of them might involve care homes. The one in the northeast is likely to be in the south of the patch. We haven't had confirmation yet, but it's likely to be in the Tees Valley CCG area, and is a collaboration between the CCG, the primary care staff and their community teams, but also the respiratory team in the hospital, particularly at James Cook, to try and help monitor these patients, some of the time using the respiratory nurses. The other thing I wanted to just briefly mention is that there was a RCGP and NHS Network co-organised webinar specifically about the role of primary care in care homes during COVID-19, and there was quite a lot of discussion about pulse oximetry and virtual wards and so forth, and you can see the link on your screen about how to find it. It's not particularly difficult to find if you Google it as well. So that's all I wanted to say on that topic, but I hope that's useful and gives you some idea about how it links to the work that we've been talking about so far in the webinar. And I think I'm handing you back to Sarah to play a video about pulse oximetry.
Hello. Oxygen saturation describes the level of oxygen in your blood. You may also hear people refer to it as blood oxygen level. You need to be able to measure this using a pulse oximeter. A pulse oximeter measures oxygen levels using a probe that is usually placed on the end of someone's finger. The display screen shows the oxygen level as a percentage. Pulse oximetry is very useful as it identifies low blood oxygen levels quickly. There should be a pulse oximeter available in every area where news is being used. Using pulse oximetry is straightforward. Ensure the pulse oximeter is clean and working. Gain consent to take a reading and explain what you are going to do. Select an appropriate finger for the probe. Apply the probe. Ask the person to rest their hand. Allow the oximeter to take a reading. It usually flashes a bit before the numbers appear. Write down the number on the paper news chart or your electronic device. You must also write down whether the reading has been taken while the person is breathing normal room air or is on oxygen therapy. If so, record how much oxygen they are being given. A normal oxygen saturation range is 96% or higher. There is a group of people who live with a lower level of oxygen in their blood. These are people with lung conditions such as COPD. A usual oxygen saturation for them is between 88 and 92%. If this is the case, it should be clearly written in their notes by their doctor or lung nurse. Otherwise, assume that normal is 96% or higher. The person must have a good pulse and good blood flow to their fingers for the pulse oximeter to work. Cold hands, dehydration, or a dirty probe can make it difficult to get an accurate reading. Nail varnish and false nails can also affect the reading. You may need to talk to a senior colleague for advice on whether the varnish or nails need to be removed. If you have any questions about using a pulse oximeter, please speak to your manager or a senior colleague.
Thank you for that, Tony. So we felt it was important as an opportunity to tell you about something that was coming over the hill, as it were, in terms of oximetry and in particular in response to COVID, which we're not clear yet whether or not it will impact directly on care homes, but there is certainly a conversation, and we felt it was worthwhile highlighting oximetry and what is likely to be coming in the next few weeks and may or may not be directed at care homes in the first phase. We're not entirely certain of that. So if we go on to the next slide, please, Sarah. Yeah, so someone's just asked a question in the chat box about the videos. So we will include a link to the whole suite of videos. So the videos that we've played you today were actually developed by Health Education England in partnership with the Academic Health Science Network and a number of other organisations. As you will have seen at the end of each video, there's a slide that comes up with the participating organisations. And actually there's a suite of 14 different videos. And they were originally developed in response to sepsis and serious illness. And we've then adapted them to think about deterioration and what a news score is, how to do a news score, but then also some issues around treatment escalation plans, resuscitation, and recognised deterioration in people with learning disabilities. The idea behind those suite of videos is that you can access them, they're publicly available on YouTube, and that you can dip in and out of them as a learning and teaching resource as and when you feel the need. We wanted to use the webinar today to introduce you to 2 or 3 of those videos so that you could see how good they were, how useful they were, and you can think about whether or not you want to incorporate those. Now, I'm reliably informed, but I don't know quite how this works, that if you complete all 14 of the videos, you actually can get a certificate of some description for that. I need to go and check that out. And if anybody wants to know about that, please email us afterwards, and we'll try our best to find that out and give you some additional information. So we're coming towards the end of our discussion now. Next slide, please, Sarah. So we're going to have a panel. Now we've got a Q&A. I think we're probably about 20 minutes ahead of schedule, so that's great for all of you who have busy days. So we will take 10 minutes or so to have any questions from you as a group. I've just been made aware that 1 or 2 people might have an issue accessing the chat box. So the other facility that you have is that on your taskbar along the bottom of your screen, when you wiggle your mouse, there's also a hand, and if you click on that image, you will raise your hand in the meeting, and we will try our best to come around to you if you do have any questions. So we've got a panel of people who are joining us for this. There's me, Tony and Karen, who you've heard from before, and we're going to be joined by Oliver James, who's our erstwhile ex-medical director, who still works on this programme with us a day or 2 a week, and also Catherine McShane, who is a specialist dietitian for County Durham and Darlington, but also is a key figure in the rollout of the Health Call digital platform in Durham and Darlington into the care homes there. So I'm just going to look across at the chat box, and I see that we've got a couple of questions in already, and the first one is a question for Karen, and it says, how well has news, etc., been received in the specialists' homes, e.g. learning disability and mental health?
Yes, hello. I've just replied back there in the box, but it's fine. We haven't actually, unfortunately, been commissioned into the learning disabilities and mental health homes yet. It was the adult residential and nursing homes. So I'm hoping that we're going to expand into those areas. So unfortunately, we haven't gone into those homes yet.
Oh, thanks, Karen. It was Jill May in here that was asking that question. Hi, from Newcastle. Just simply because you know, we're looking at the primary care networks and the DES specs, etc. So that will mean that a lot of work is going to be kind of rolled out across residential and LD mental health morbid specialist homes as well, to have a link into them. So obviously that even with residential homes, it's very different. Thinking as a nurse in a way, doing news and news too, and that was the other thing. I was just wondering if that had been difficult, you know, in terms of who's responsible for doing news too, if you've got a residential home that doesn't have nurses.
Yeah, I can certainly answer that, and it's a very positive answer really, because we haven't hit sort of any hurdles in a sense of whether it's a residential or nursing home. Quite frankly, there's been no difference. I go into the homes themselves and do the training for all of the staff, so whether they're residential or nursing. It hasn't made any difference, which is good. I did sort of 3 years back when we started this journey, I did anticipate, I'm a nurse myself, and I did anticipate that we would possibly sort of, or people may be thinking, well, I'm not a nurse, and you know, this is a very clinical thing to do, and lots of anxiety around that. And I did anticipate it, and don't get me wrong, there has been initially, that's what people think, but when the staff have the training and then actually use it, but then most importantly realise that they're not expected to make a clinical decision. And I think that's the thing. So it's they think that they're doing this to make a decision, and it isn't. It is a skill that they can learn and then practice with support of our community clinicians, and we have like champions that we would hope to support their own staff. But no, I haven't had sort of any resistance from the carers who aren't clinical.
That's often the problem in the res settings, is that people are not really covered to take OBS and things like that. And that was just I just wondered how that had worked really.
I'm just going to jump in there, Karen, because I think just to echo Karen's experience is actually we've got this kind of project running across 6 or 7 different localities, and every single one of them are developing in residential and nursing homes.
Yeah.
And not a single one has come up with an issue around non-qualified staff taking a set of observations, because it's a very, very simple set of observations. And when trained well, and using the right kind of kit, because it's a lot of it's, you know, blood pressure cuffs these days are not the same as blood pressure cuffs when I did my nurse training back in the late 80s, where you sat with a swig on your ears and you listen for differences in tone and all the rest of it. Actually, you put it on now and press a button, and then it gives you, and all you've got to do is read the numbers up front. So it's a very different experience. I do want to ask Catherine if she can come in there. I'm not sure whether, Catherine, you've done any work in Durham in the learning disability or mental health homes yet.
No, we haven't.
Okay.
But South Tyneside are about to start doing it within the learning disability.
Okay.
So it's something that we've got on our radar for. But yeah, just echoing what you said there, Tony and Karen, that I was quite surprised myself how many residential homes were already taking the readings. And a lot of their senior carers have got clinical skills training, which includes all of that. And actually, the bigger problem a lot of the time was using the tablets rather than actually taking a BP.
Yes.
For it. So it was more the technology. Sometimes it was more of the anxiety rather than any of the readings, of taking any of the observations.
Dave, can I chip in as well?
Yes, Tony.
Just to mention that East Midlands AHSN in particular has got a real interest in news in learning disability and other mental health settings, and so they've got materials and stuff which might help with this agenda.
Oh, brilliant! Right.
Thank you for that. There are some things happening nationally within the AHSN network, which is specifically looking at deterioration in mental health settings and other settings. So as and when they become available, we'll make sure that we circulate those and we get those out to this group for information. So we've got one more question, which is also from Jill, which is actually about who is responsible for maintaining the news kits. And I think actually we've got a variety of different approaches to that across the Northeast, and it's one of the things that we don't struggle with, but it's an interesting question because they do need calibrating. So in Sunderland, for example, the kit is owned by the CCG, and their community equipment services recalibrate kit and provide the care homes with updated kit. In County Durham and Darlington, the kit is gifted to the care homes, and it becomes the care home's responsibility to do that.
Right.
So I think there is no straightforward answer to that. We just need to think about what's right for your locality, but we do need to think about the fact that the kit will need to be maintained by somebody at some point is an important issue. Right, I've got 2 people with their hands up. I think Bainham was first. So Bainham, would you like to give us your question and then put your hand down, please?
Not necessarily a question, but just to touch on what Catherine said, we're dipping our toes in the water and looking at mental health residential and LD residential. So obviously it's very early days yet, but anything obviously that we'll learn or pick up along the way, happy to share with people if they want to look at the same arena. We've already started discussions with Catherine and others from Health Call about what that potentially might look at. Is it's whilst the news 2 score be useful, there's some additional stuff we want to look at.
So I think what we might do there as an AHSN, from an AHSN perspective, is just reach out an olive branch right here and now and say that actually we have a regional steering group for the well-connected care homes, and as part of that we could quite easily set up a subgroup that wanted to look at mental health and learning disability settings. And we can then develop a conversation and develop some learning from the work that Catherine and Bainham and others are doing. And we can just share that amongst that network immediately. So if again, people feel that would be useful, the AHSN would be happy to step up to that plate and set up a subgroup, which is specifically going to look at those areas. And we can be helpful in that way. I'm going to move us on to the next person who's got the hand up. I think that's Sabina.
Hello there, Dave. My name's Anne Bell. Sabina and I are sharing the presentation just instead of having 2 laptops on.
Welcome.
Right. Thank you. It might seem a very simple question. It's just, will we have access to a Word document or an Excel document for the news too, so that we can print off and use?
Yes, so the Is My Resident Unwell tool is available as a printable PDF, and we've also got a poster that goes alongside that you can put up in and around your care homes in the staff room or the office or wherever it is. So we have those available. That when we send out the link to the recording of this webinar, we will also send out a link to those documents.
That would be great.
We deliberately designed the documents so that in the right hand corner of the front page you can stick your own organizational logo on,
Right,
so that it becomes relevant for you and your part of the patch. All we ask is that you leave the AHSN logo on. It's open copyright, so all we ask is that if you reproduce it or use it in a different way, you acknowledge the source.
Lovely, that's great. Thank you very much, Dave. Thank you.
And we are hoping that as digital applications become more widely used and available, i.e. the Health Call platform, that the Health Call platform already incorporates a lot of the contact questions about end of life plans, and it already incorporates SBARD. And what we're hopeful is that we can work with Health Call in the next iteration of the app so that it will also include soft signs. So we're all on that journey together to make it as widely available as we can. So yes, in short, yes, we'll get the link to you.
That's great. Thank you very much, Dave.
I've just popped it in the chat as well.
Oh, okay. So Tony very helpfully has already popped the link to the videos in the chat box for those of you who can cut and paste, and also the link to the Is My Resident Unwell tool and poster. We had another question which is from Mandy, which is around, would the quality teams within commissioners be able to promote this work, or would it only be for AHSN? I think the short answer to that from an AHSN perspective would be, please promote the work, and the AHSN will be happy to work alongside any parts of the system or any locality teams who want to try and implement it. We are here to support that work, so please contact us afterwards. Are there any more questions or any more raised hands? Is there anything from the panel, while people are thinking, that they feel it's important to say that we may have missed? Oh, we've got one more hand that's come up. So if so the panel have now got an opportunity to think about it, because I surprised them with that. So Dan, you've got your hand up.
Yeah, hi, it's Dan Cowie, just wanted a GP. Can I just ask a quick question, Dave? I was on the webinar with the sort of the Royal College, looking at the sort of the virtual ward stuff, and they really came across about the news too, saying not to be used. Could you tell us really what that sort of rationale is? Because they also talked about the SBARD and the news too, and not using them remotely clearly. So what was their concerns roughly about that? Because they didn't spell it out clearly, apart from saying there's lack of evidence to use it remotely. But I didn't really fully understand what they were getting at.
Do you want me to try that one, Dave?
You can do it, then I'll jump in after you.
Okay, so there is a debate, shall we say, going on in particularly amongst GPs about the role of news. If you happen to have a BJGP, so British Journal of General Practice, if that's popped through your letterbox recently, you'll find an editorial in there, 2 papers on the subject, and also Alison Tavare, who's a key GP in this, and who was on that webinar talking about her experience of it. The issue is really to do with whether news works, the total news works as well in COVID as one would hope. So pre-COVID, we used to be very keen on saying, don't use individual parameters. The whole news score is the bit that's validated, and it allows for more subtle changes in physiology to be picked up. If you're too focused just on temperature or just on blood pressure, that can be a problem. Now, since COVID arrived, there seems to be this greater emphasis on oxygen sats. So they have sort of shifted their position a little bit and said sometimes it will be appropriate not to do a full news score There will be situations, particularly when we were near peak of COVID, where, for example, a blood pressure isn't going to add all that much, and incomplete news is fine, particularly if it's already raised. You could go with an incomplete set of news, and that will still tell you most of what you need to know. And there is this feeling that the 3 parameters that they talk about in virtual wards, so pulse and temperature and oxygen sats, are probably the most important 3. But I don't think they were trying to say don't use news. They were saying it can be very useful. It's certainly very useful in all forms of deterioration, but there might be limitations for it in COVID, and there might be some situations where you can live with a less than complete set of news. That would be my interpretation.
Okay, thank you, Tony.
Great, that's really useful. Thank you.
Okay, and we've got one more question that's come into the chat box, which was from Phoebe, which is around, is there a key on scoring news as part of the tool? Yes. Karen and Catherine, we can pick that. No, there isn't, is the short answer.
I was just typing away the answer there, but yeah, sorry to put in there, Dave, but there is no key as such for an escalation. However, once the news score is recorded or worked out, whether that be digitally or on paper, each area would have their own individual escalation tool, if that makes sense. So obviously an escalation tool used in a hospital setting would be very different to an escalation tool used in a care home setting. However, it's still the same news score. So does that make sense?
My interpretation of that question was slightly different, Karen, in that I think Phoebe was asking us whether or not is there a key to calculate the news score rather than interpret the news score?
Oh, okay.
The answer as part of the tool is no, and the rationale for that is because actually what we want to do is that's part of the education and training that comes alongside the use of the tool. And actually for the vast majority of the care homes that are starting to use the tool at the moment, that is digitally calculated. Mm-hmm. So actually you don't need to teach people the algorithm for calculating the news score, because actually all you have to do is input the information onto the tablet and the tablet does it for you. Having said that, if that is an emerging issue for non-digital capable care homes, then we can develop that alongside you. But at the moment, there isn't one. Does that answer your question, Phoebe?
Yeah. It does. It's just. Oh, sorry. 1 second.
All right. That was lovely and echoey.
I'm a physio and work in intermediate care, and I don't think any of the care homes that we go into have got a digital way of recording any of those like parameter data. So they would probably need to either have a key on what a certain reading would equal as a news score.
Yeah.
I think Phoebe, I think when I went into all of the homes here at Hartlepool and Stockton, some of the homes, particularly the nurse and dementia homes, they were already using news as an assessment tool. They didn't have a digital format, so they used the charts, like the observation charts that you would see in the hospital, and the same news charts that you would see anywhere would work anywhere, because the principles of doing the news score would still be the same and you would still get the same score. So even if it was a paper version, then you would still get your scoring. So even without a digital tablet or anything like that, you can still use it using a paper news score, which would looks the same as what they would use in the hospital setting, if that helps.
I'll go a step further as well, Phoebe, and say that one of the subgroups that we had for our steering group is around education and training. And I know from the people on that group that they are more than happy to share the education and training tools that they're currently using with their care homes, which includes that element of how to calculate a news score. So it does exist, but it doesn't exist on the tool itself. So, and we are more than happy to include you in that education and training forum going forward and share the tools and training materials that we've currently got. On the agenda for this summer was actually developing a regional set of training tools, which has just been scuppered because of COVID. So we are aware that we need to do something around that, but there are some really good information out there. And Tony has once again surpassed himself and has put a link in the chat box to a piece of information which is exactly how to do that from one of the Royal Colleges. So Phoebe, let's pick it up outside of the webinar, if that's useful. Okay. And we've got one more question from Julie Gregory, which is, when is News 2 going to be rolled out in the South Tees area?
So I've just replied and asked if she means the virtual ward pilot, which I think she does. And the answer is there's quite a lot of discussion going on about how to do it. Simon Stockley, some of you will know from the RCGP sepsis work in particular, and from the webinar, is involved in that for HAST, and Janet Walker for South Tees. We haven't had confirmation from NHSE about when the pilots or the vanguards or whatever we're going to call them are going to really start, but and I'm not quite sure where we are with the arrival of the pulse oximeters as well. So the short answer is I don't know, but supposedly very shortly.
And Julie, I can also say that if you mean the News 2 score and care homes generally, the answer is that there's a conversation happening with South Tees at the moment around how that might be done in terms of a digital intervention, but also in terms of using the tool. So we know that South Tees in particular is not now a standalone entity and is part of the Tees Valley CCG. So in two areas of that, Hartlepool and Stockton and Durham and Darlington already have News 2 rolled out to every single care home and have a digital application of that, but South Tees does not. So I know that it's high up on their agenda because they have an outlying area. But as for a specific time frame, I don't have one. But I can try and we are pushing, and it will happen, and it will happen fairly soon, I think. So looking along, Daniel Cowie, you've still got your hand up. Is that in error? Should that have gone down, or is that another question?
That should have went down, sorry.
It's all right, thank you, Dan. Okay, so there's one question just coming from Mandy. How does this link to Restore 2? So the answer is this is an alternative to Restore 2. Restore 2 was one of the tools that was looked at by our North East and North Cumbria expert panel, and they didn't want to roll out Restore 2. Their opinion was that Restore 2 is an excellent tool, but the one part of it that they didn't fully support was the escalation element to it. And that was because we haven't had those kinds of detailed discussions around escalation with our system. So it was felt that developing our own tool for the North East and North Cumbria was the most helpful way forward at that time. I am aware that nationally, Restore 2 is a tool that's been used in a lot of other areas. And actually, we're not averse to that at all. But the decision by the expert panel in last summer was that we didn't want to go with Restore 2. We wanted to write our own. Okay, so
Dave,
yes, Oliver.
It's Oliver here. Just to emphasise that the panel felt that Restore 2 was a little bit clunky, and thanks to the amazing amount of work they put in, sort of chaired by you, our view is that our tool is a little bit more user friendly, and that's been borne out by the users, as it were, in our region. And this tool is our tool is also nationally recognised as being one of the tools for soft signs and so on in particular, which can be used. That's the way it is.
Thank you, Oliver. Okay, I'm going to have one last look around for any show of hands or any questions in the chat box. And if not, I'm going to move us on to the last final slide. Okay, so it's just to say next steps. So firstly, we we are recording the presentation, and that presentation, the copy of that will be shared with you so that you can circulate it amongst your colleagues and you can use it for reference. Please do encourage your colleagues who were not able to attend today to click on the link and watch it. Hopefully you found it helpful and you can refer back to it. The third bullet point down is perhaps the most important one. We do want you to start using this tool. It is available as a paper tool. We want you to discuss it locally. We want you to integrate it into your processes and your pathways, because we know that where it is integrated into processes and pathways, it really helps. We also know that deterioration is a key issue in the care home sector, both for COVID and non-COVID deterioration. And actually, this is a really useful way of just helping your care home staff think about what they're seeing and pulling together useful information as part of that process. There is some emerging evidence to say that the mortality rate in care homes and outside of care homes is actually not just COVID related. So that escalation is also about non-COVID related deaths. And actually, we need to be mindful of that as we move forward. And that's one of the reasons we're seeing, you know, people are not turning up to hospital, they're not referring themselves, and actually we're not necessarily picking up on some of the subtleties around deterioration, either in our own health or in the health of the people that we care for. So the quicker we can start a conversation about that, the better as we move through the summer and into winter. And the final point on there is that the AHSN is here to support that process. So if you want to engage in a local conversation about how you can use the tool, how you can apply it, how you can get some investment in digital, or when digital might be coming your way, and how you can maximize the benefit of that, because nearly every single locality in the northeast North Cumbria is now on that digital journey. So News 2 and Soft Signs, and hopefully this tool will be coming your way, and we are here to support. Final slide, please, Anne. If you do have any requests, if you do have any questions, if suddenly something comes into your mind when you go off to make a cup of tea when this webinar finishes, please do email us. We are here to help. We will come back to this. We will run more webinars. We are open for local conversations about how we can help implement this tool over the next 6 months. And finally, I would like to thank the panel and the presenters for a sterling effort. I think as our first Teams webinar, this has gone really well. So thank you very much for that. I would like to thank from the bottom of my heart all of the people who've come along to participate and watch and join in the conversation about deterioration and care homes. Thank you very much. Hopefully our paths will cross again over the next 6 months as we start to roll out the tool. Thank you very much, everybody.